Any causes, children? Sachin. Good morning, dear students. We have completed the ear and nose and paranasal sinuses. Then we come to the next organ, which is the oral cavity, and we'll slowly discuss about the structure of the oral cavity and the various physiological functions and some important lesions of the oral cavity. Now, to start with, basically I keep stressing that anatomy is the most important thing that you need to understand. What is normal and what a disease, how a disease transforms or changes this anatomy and to interfere with the physiology, normal physiology of any organ. So today we will deal with the oral cavity anatomy. Now, oral cavity, teacher, is the beginning of the digestive tract. It starts there, and then, as the nose is the beginning part of the respiratory system. Now, this oral cavity, any cavity for that matter, if you take up, has got a roof, there, and a floor, and it has got an anterior end, which has got a posterior end, and then you have these lateral walls. Now let us see how these structures are there to perform the functions which the oral cavity does. So let us start with the roof. The roof of the oral cavity is consisting of the hard palate, which consists of partly the maxilla and partly the posterior 1/4 of it is the palatine bone. Then attached to that is the soft palate, which is a muscular structure. We will go into the details of this later, the hard palate. Then we go to the floor of the oral cavity, which is formed by the muscles. This is the mandible and this is the hyoid bone. So there is a muscle which starts from the mandible to the hyoid bone, which is called mylohyoid. Mylohyoid. This mylohyoid is the one which forms the oral diaphragm. That is the one which forms the floor, which is one of the first muscles, superficial most muscle, to the which forms the floor. Then just above the mylohyoid muscle, from the mylohyoid line from the mandible to the hyoid bone, there are four tubercles, and from the inferior tubercles there is a muscle called geniohyoid. That is also from the mandible to the hyoid bone. That also is the structure, a muscle which forms the floor of the oral cavity. Then above that, the genial tubercles, what we said, the upper two, there is a muscle which is attached to the tongue, which is called genioglossus, from the genial tubercles to the tongue. So these are the three layers: mylohyoid, geniohyoid, and genioglossus. These are the muscles. And there is another muscle which is called the hyoglossus, from the hyoid bone to the tongue. So these are the muscles which are attaching the entire fleshy tongue. Tongue consists of muscles, nothing but muscular tissue. There is no cartilage or bone. It's a muscular tissue. So the tongue is attached to the mandible anteriorly and posteriorly to the hyoid bone. So those are the attachments of the tongue. So apart from these muscles, the mylohyoid, the geniohyoid, and the genioglossus, the tongue per se consists of two kinds of muscles, which we will discuss later. But it's a muscular organ, totally muscular organ, which forms also a part of the floor of the oral cavity. So the hard palate with its maxilla and the palatine bone and the soft palate forms the roof, and the floor is formed by these muscles which are attached to the mandible and hyoid and to the tongue. So these are the muscles and the tongue, these are the ones which form the floor of the oral cavity. Then we go to the anterior extent. Anterior limit is the anterior. We have the lips, the upper and the lower lips, they close together and form what is known as the oral fissure. And that is the anterior limit of the oral cavity. And if you go posteriorly, there is this muscle. There is this muscle called the palatoglossus muscle, which is like an arch there, from the palate to the tongue. The palatoglossus muscle, this arch is the one which demarcates the posterior limit of the oral cavity, and behind this oral cavity is the oropharynx. So the anterior limit is the oral fissure, which is formed by the two lips, upper and lower lips joining together, which forms a fissure. That is the anterior limit. And posteriorly, the palatoglossus muscle, which forms the posterior boundary of the oral cavity. So we have dealt with this roof, we have dealt with the floor, we have dealt with the anterior and posterior extent of the oral cavity. And Then we go to the lateral aspects. The lateral aspects, you have the cheeks. The cheeks are the ones which form the lateral boundaries of the oral cavity. Okay? And this cheek, if you take from outside, it consists of the skin, then the subcutaneous tissues, the buccinator muscle. Let me show you the buccinator muscle. This is the muscle. This is the muscle which is present in the cheek. So from outside you have the skin, then subcutaneous tissues, and the various tissues deeper to that, and it is the buccinator muscle which is attached superiorly to the maxilla, inferiorly to the mandible, which is embedded in the cheek, and deeper to that buccinator muscle is the mucous membrane which lines the entire oral cavity. So these are the boundaries of the oral cavity. Let us try to brush these things and try to get the correct picture. So the roof is formed by the hard palate and soft palate, partly formed by the maxilla and the palatine bone, and soft palate by the muscular tissues, organs, and the floor, the mylohyoid, geniohyoid, genioglossus, and the entire tongue which forms the floor. Anteriorly, the oral cavity starts from the oral fissure which is formed between the upper lip and the lower lip. Then the posterior boundary, as we said, the palatoglossus muscle which extends from the palate to the tongue. Anterior, it joins the tongue at the junction of the anterior 2/3 and the posterior 1/3 of the tongue. And then this is a diagrammatic representation of the oral cavity. This is blue one is the nasal cavity which is above the oral cavity. The floor of the nasal cavity is formed by the hard palate, the maxillary bone and the palatine bone, and that forms the roof of the oral cavity. Anteriorly oral fissure and posteriorly the oropharyngeal isthmus. The oropharyngeal isthmus is nothing but the continuation of the oral cavity into the pharynx, and this is demarcated by the palatoglossus muscle, okay, which comes from the palate and joins the tongue at the junction of the anterior 2/3 and posterior 1/3. And lateral walls of the nasal of the oral cavity are formed by the cheeks, and there is a muscle there which is called the buccinator muscle. Then the oral cavity proper is once again divided into two regions. The two regions, let me show you this. The two regions. The one is called the vestibule. Vestibule, the vestibular part is the space between the lips or the cheeks being separated by the upper and lower arches, the maxillary and the mandibular. See, these are the teeth which contain the teeth, the maxillary and the mandibular. So when these two are closed, when the teeth are approximated, the space between the cheeks and the bones maxilla along with their alveolar margin containing the teeth, and similarly the mandible with their alveolar margin with the teeth. The space in between is called the vestibule. Now this vestibule can be opened anteriorly by opening the lips or opening the mandible wide open. So anteriorly, the anterior fissure, the vestibule can be seen when you open the mouth, and posteriorly the vestibule is in connection with the oral cavity, from a small region called retromolar trigone, from the retromolar area. Now if you take up the vestibule opposite the second upper molar, there is a in the cheek there is a small papilla or projection, and on the summit of which there is a small opening of the duct of the parotid gland. Okay, so that is the structure which opens into the vestibule, and that is the one which drains the secretions from the parotid gland into the vestibule, just opposite to the second molar tooth upper. And the entire oral cavity is lined by what is known as the stratified squamous epithelium, and this is what it is. The description is the outer oral vestibule, which is horseshoe shaped in between the dental arches, okay, and the oral cavity proper, which is enclosed by the dental arches inside. So let me show you another diagram here. Yeah. So this is the oral vestibule between the teeth, the alveolar margin and the cheek, and whatever is inside the alveolar margin, upper and lower, is the oral cavity proper, okay, where you have once again, this is the vestibule and this is the mandible with its alveolar margin and the tooth. That's the vestibule, and this is the oral cavity proper. It's the oral cavity proper. Okay. Then we studied the lateral wall, which consists of cheeks, which can contain a muscle which is called the buccinator muscle. Now the floor of the oral cavity we have already described earlier, and for diagrammatic understanding, this is the muscle. This is the mylohyoid line which is attached to the mandible, and this is the hyoid bone. And so there is a muscle which is just horizontal, and above that there is another muscle from the genial tubercles to the hyoid, which is called geniohyoid muscle, which also forms the floor of the oral cavity. Then we go to the tongue proper. The tongue is a muscular structure, as I told you. It consists of only the muscles, and these muscles, there are two groups of muscles, and basically the tongue, as I told you, is attached anteriorly to the mandible and posteriorly to the hyoid bone. Rest of it is free. Okay, and it's a triangular muscle, the apex of which is a little blunted, and which forms the anterior end, and it is divided into anterior 2/3 and posterior 1/3. The anterior 2/3 is the one which is in a horizontal plane, whereas the posterior part of the tongue the posterior 1/3 of the tongue, which goes into the pharyngeal part of the tongue, which forms the anterior wall of the pharynx, oropharynx. Now, the root of the tongue is attached, as I told you. The superior surface of the oral or anterior tooth of the tongue is oriented in a horizontal plane. This is horizontal and this is vertical. And it consists of on the surface of the tongue, the pharyngeal, the oral cavity and the pharyngeal surface of the tongue is covered by, once again, this stratified squamous epithelium, and at the junction between the anterior 2/3 and posterior 1/3 is a V-shaped terminal sulcus which is present, and this terminal sulcus forms the inferior margin of the oropharyngeal isthmus. We have seen the superior margin and the lateral margins is the palatoglossus muscle, and it joins the tongue at the anterior 2/3 and posterior 1/3 junction, and the sulcus is the one which forms the demarcation between in the floor between the oral cavity and the oropharynx. And at the apex of this sulcus, V-shaped sulcus, at the apex of the V-shaped sulcus, this is the sulcus, there is a small opening which is the foramen cecum, from which the thyroid develops and formed and then descends down into the neck. That is called the foramen cecum. And the tongue has got, it is not a very smooth structure. It has got various papillae, which are called the filiform papillae, the fungiform papillae, the valate papillae, which are situated in the V shape, which are there. See, these are the valate papillae. And then you have foliate papillae, which are linear folds of mucosa on the sides of the tongue near the terminal sulcus. Now these are the ones, the foliate papillae. So you have the fungiform papillae, the filiform papillae, and the valate papillae, which are 8 to 12 in number, which are at the V-shaped junction between the anterior 2/3 and posterior 1/3. And on the lateral part of the margin of the tongue, you have the foliate papillae. The papillae are the ones which increase the surface area of the tongue, so that the food comes in contact with them. And all except the filiform papillae have the taste buds on their surfaces. Okay? They contain the taste buds. Now the inferior surface of the tongue is once again contains some folds, and there is a midline fold which is called the frenulum of the tongue, which is continuous with the mucosal covering of floor of the oral cavity, and overlies the lower margin of a midline sagittal septum, which internally separates the right and left sides of the tongue. This is what it is. This is the frenulum, and the one which separates this is the median septum, which separates the tongue into two halves. So that is the mucous fold which is there from the floor of the tongue, and then it is the one which comes to the anterior part of the tongue. That is the frenulum. And just at the junction between the floor and the floor of the oral cavity, there are two small projections. wherein the submandibular salivary gland ducts open. Submandibular salivary ducts open. On either side of the frenulum, you have the vessels, the deep lingual vein, which are very prominently seen. And lateral to that, you see another fold, which is the fimbriated fold. So these are on the ventral aspect of the tongue, and this is the floor of the oral cavity. Now there is a just beneath the mucous membrane of the floor of the oral cavity, there is a gland, the salivary gland. There are three major salivary glands which are in pairs. One is the parotid gland, the other one is the submandibular salivary gland, and third one is the lingual gland. So the sublingual gland is the one which also opens sometimes directly into the floor of the oral cavity, and or sometimes opens via the submandibular duct. So that is as far as the sublingual fold, where you have the sublingual salivary gland. That is as far as the oral cavity floor is concerned. Okay. Then we go to the pharyngeal surface of the tongue. The mucosa covering is irregular, and contour, as I told you, becomes vertical. And there are so many small nodules of lymphoid tissue in the submucosa. These nodules are collectively called the lingual tonsils. Okay, these are called the lingual tonsils. And the thing that you have to note is there are no papillae on the pharyngeal surface. The papillae, the various papillae that we have described, are not present in the posterior part of the posterior one third of the tongue. Then we go to the muscles which are innervated, which form the core of this tongue. They are grouped into extrinsic muscles and the intrinsic muscles. The extrinsic muscles are the ones which are coming from the sides, or which are the styloglossus muscle. Let me see if I can show you the styloglossus muscle. This is the styloid process, and the one which is coming into the tongue, that is the styloglossus muscle. Okay. Then you have the palatoglossus muscle from the palate to the tongue, palatoglossus, and we have studied hyoglossus muscle from the hyoid bone. This is the hyoid bone, from this to the tongue, hyoglossus, and the deep from the floor, genioglossus muscle. These are the extrinsic muscles: the palatoglossus, the styloglossus, the hyoglossus, and the genioglossus muscle. These are the muscles which are the extrinsic muscles. Then we go to the intrinsic muscles. The intrinsic muscles are the ones which are longitudinal muscles. When they contract, the tongue becomes short. There are transverse muscles which, when they contract, they make the tongue narrow, and then you have these the vertical muscles. So you have the muscles, intrinsic muscles, in three different directions. One is the horizontal, the longitudinal, and the vertical. Vertical are the ones which make the tongue thin. Okay. So these are the intrinsic muscles of the tongue. All these muscles of the tongue are innervated by the hypoglossal, except the say the palatoglossus muscle, which is supplied by the vagus. So those are the muscles that which comprise the tongue. Then the vascular supply is the artery and the lingual artery, which is a branch of the external carotid artery, which is the major contribution. In addition to the tongue, the lingual artery supplies the sublingual glands, the gingiva, oral mucosa and floor of the oral cavity. The veins are the dorsal and deep veins, lingual veins, which usually form a kind of a plexus in the maxillary region, pterygoid plexus, and ultimately they join the interjugular vein with the neck. Then we come to the nerve supply. When we come to the nerve supply, the nerves which supply, nerve supply usually is divided into, one is the sensory, the other one is the motor. Now in sensory we have general sensations, then we have the special sensation, that is the taste here in this, and the third one is the sympathetic and parasympathetic. These are the ones which are secretomotor fibers. So the sensory are the general sensation like the touch, pain, temperature, pressure, and they are the ones, they are by the lingual nerve. By the lingual nerve, which is a branch of the mandibular division, that is the 5-3 or V3 it's called. So that is as far as the general sensation is concerned. When you go to the special sensations, special sensation here is the sensation of taste. The taste sensations are the ones which are carried from the tongue via the lingual nerve, and then from there it opens up into a nerve which is called the chorda tympani. This chorda tympani enters the middle ear cavity, and then from the middle ear cavity it joins the facial nerve, and then from the facial nerve how it goes through the internal artery canal into the nucleus, salivatory nucleus. So that is the sensation, the special sensation of taste, which is carried by the lingual nerve, and the further as it goes, it gives a branch which is called the chorda tympani, or which runs along with the lingual nerve. Okay, so that is as far as the special sensation is concerned. And the secretomotor fibers which travel in the facial nerve, once again they come via the chorda tympani nerve and then join the lingual nerve, and then in the submandibular region it forms a ganglion, submandibular ganglion. From there these parasympathetic fibers, secretomotor fibers, are supplied to the submandibular gland and the sublingual glands. So sensory, we divide them into general sensation, which is by the lingual nerve, which is by the mandibular division, the lingual nerve. Then the special sensation, taste, by the same lingual travels along with the lingual nerve. It separates into chorda tympani, joins the seventh cranial nerve and into the salivatory nucleus. Then the third one, secretomotor fibers, they come via the chorda tympani once again, and then they form a ganglion here, and from there the secretomotor fibers travel in the lingual nerve and supply the secretomotor fibers to the submandibular and sublingual glands. That is as far as the sensory component is concerned, the sensory and the motor secretomotor fibers. Now the muscles of the tongue are the ones, the motor, which are by the hypoglossal nerve. This is the one which shows the blood supply, the carotid artery, the common carotid artery, how it divides into external carotid artery and the internal carotid artery. And this external carotid artery is the one which gives off a branch which is called the lingual, and that is the major supply. So that is as far as the blood supply to the tongue is concerned. Now the innervation, as I told you, the lingual nerve, the facial nerve, the secretomotor, the taste sensation and secretomotor fibers. Whereas from the posterior third of the tongue, the sensation of taste is by the glossopharyngeal nerve. So this is once again the general sensation. This is what, in a brief, what has been already told to you, and these are the extrinsic muscles and the intrinsic muscles. Then the roof of the oral cavity is formed by the hard palate anteriorly, which is partly formed by the maxilla, and the posterior 1/4 is formed by the palatine bone. And how to these palatine bone posterior margin, the soft palate is attached. Okay, this is the soft palate. And the palatoglossus muscle, which forms the posterior end of the oral cavity. And beyond that is the oropharynx. Now, in the oral cavity, you have the maxilla and the mandible and the various teeth. Teeth are the milk teeth are 20 in number, whereas the fully blown adult consists of 32 teeth. And if you take 1/4, there are 2 incisors, 1 canine, 2 premolars and 3 molars. This is structure, and these teeth are into the alveolar margin of the mandible or the maxilla. And this is the blood supply of the teeth. The upper part of the upper teeth are supplied by the maxillary division, whereas the lower ones are through a inferior alveolar artery, okay, and which supply all the lower teeth. And if you see the nerve supply, once again the upper teeth are supplied by the anterior, middle and posterior branches of the maxillary division, whereas the mandibular division, the inferior alveolar nerve which travels in the canal, supplies all the teeth of the inferior, the mandible. With this brief anatomy, and we go into the diseases of the oral cavity. There are several disorders, and we discuss some of them which are important for us. Now, the first one is the oral submucous fibrosis. Oral submucous fibrosis. Now, this oral submucous fibrosis is quite a common condition which we see in our country, and this is particularly because of the tobacco chewing. It's a chronic painless process, and where there is a white patch in the oral cavity, particularly in the soft palate region, and the etiological factor mostly is the pan, the tobacco or the supari, which is kept in the oral cavity for a long time. And second etiological factors, the cigarettes and bidi smoking, alcohol and spicy food. The nutritional sometimes are also incriminated. Localized collagen disorder, wherein there is a fibroblast proliferation and a fibrous tissue deposition. And these are the pictures wherein there is the whitish transformation of the palatal or sometimes the cheek, in the cheek region, submucosally. Now the pathologies because of the irritant, and they are usually classified into stage 1, where there is a stomatitis and vesicles, ulcers, soreness and burning sensation in the mouth, that is to start with, and intolerance to chilies and spicy food. That is the time when you have to make a diagnosis and see that's the time when you can prevent the further progress of the disorder or disease and almost lead a normal life. The stage 2, already the fibrosis has started, white fibrotic bands that occur on the soft palate, the pillars, the buccal mucosa, and they gradually progress painless and then slowly involve the muscles due to that, and so there is a Christmas in the sense they are not able to open the mouth. Then stage 3, of course, you have marked Christmas. The tongue movements are also impaired, and the poor oral-dental hygiene, leukoplakia, dysphagia, speech deficit because the tongue movements are also restricted, and submandibular swellings because sometimes the submandibular salivary duct becomes narrow and then maybe leads to retrograde accumulation of the secretions and swellings there. So these are the stages, stage 1, 2, 3, where you need to identify, and the treatment diagnosis of course is almost seen, and biopsy is the final diagnosis. The treatment consists in medical and local steroids injections with hyaluronidase and some vitamins and antioxidants, and maintaining good oral hygiene. Before that, the most important thing that you have to do is avoid the irritant, whatever it is, the tobacco, the alcohol, or pan parag, and jaw opening exercises. That is the mainstay of treatment. And if there is Christmas and the patient is not able to open the mouth widely, and various surgical procedures are being advocated by sectioning of the fibrous glands, some of the fibrous tissue is removed and split skin grafts are placed, lasers are used to cut the bands, and ultimately there is Christmas, the condylectomy for advanced cases of Christmas, wherein one of the chief muscles of mastication, the temporalis muscle, is the one which is involved, and so once you make a condylectomy, the movements become a little more. But these are all with high morbidity. The results are not very encouraging. So best thing is to stop tobacco chewing or the betel nut, the alcohol and spices that is reduced or stopped, and the vitamin supplements. That is as far as the treatment of the submucous fibers. Then we go to a condition called leukoplakia, where it's once again the oral cavity. There is a white patch that appears, and which cannot be removed like that or taken out. And this white patch the cause of these wide etiological factors of the tobacco, spices, dental sepsis. As you see here, the amount of dental sepsis that is there, and how these teeth become sharp and bite into the lateral margin of the tongue. And this chronic irritation is the one which produces the chronic hypertrophic response, the irritant, is the cause for leukoplakia. These are mostly asymptomatic, but sometimes when they grow in size, and there is always some kind of a transformation, like the nodular speckle leukoplakia with erythematous base, where it means that leukoplakia, which is a pre-malignant condition, can transform the incidence of malignancy in speckle leukoplakia is much more than the plain leukoplakia. And there is another condition which is called erythroplakia, erythroleukoplakia, which is highly potential malignant transformation into this. And the proliferative verrucous type, there is high recurrence. Treatment is by stopping whatever is the irritant, and sometimes when there is a tooth which is irritating the lateral margin of the tongue, the tooth is either drilled or taken out so that that irritation is taken away. And so usually with the medical treatment, antioxidants, and this taking away of the irritant, you can slowly the leukoplakia disappears. But if it persists then, and if it is growing in size, the biopsy has to be done, where you will know whether there is already a malignant transformation. Then you have the oral hairy leukoplakia, which is usually the etiological factor is the Epstein-Barr virus, and usually present the viral infections in the immunocompromised conditions. And if you take the histology, there is hyperkeratosis, and there is demonstration of the Epstein-Barr virus, and the treatment is antiviral. This is how the oral hairy leukoplakia appears. And then you have the erythroplakia, which I told you is much more potential for the malignant transformation, which is present in mostly the alveolar region and the hard palate. Okay? They look red in color with decreased keratinization, and so the red vascular connective tissue of submucosa is shiny. So for this, excisional biopsy and histopathological examination is mandatory. Now, trismus is a condition where there is inability to open the mouth. Now, this usually occurs in various conditions like acute painful conditions, Jacquincy alveolar infections, last molar tooth in the mal-directed, and acute otitis externa, acute parotitis. These are all the painful conditions. And painless conditions are tetanus and strychnine poisoning. Then you go to the chronic conditions, submucous fibrosis, the burns, malignancy, ankylosis of the TM joint. And staging, there is a staging is done. Stage 1, 2.5 to 4 centimeters opening. And stage 2 is 1 to 2.5 centimeters, 1 centimeter to 2.5 centimeters of opening. Third is less than 1 centimeter, and fourth one is total closure. You cannot open the mouth. So this is usually as a complication of dental sepsis, poor nutrition. And the condylectomy is the surgical procedure of this. So this is what trismus is. He is not able to open the mouth widely. So that is how stage-wise staging is done. And the next condition that we encounter in the oral cavity is the candidiasis or ammoniasis. It's a fungal infection. Most of these fungal infections are the ones which are usually present in the immunosuppressed patients. And overuse of antibiotics and steroids. Sometimes the post-RT, once again, CT, where the immunology is less. And in conditions of malignancy. And sometimes newborns, people on cytotoxic drugs, AIDS, these are the immunocompromised conditions. So they appear as white patch on the tongue and usually asymptomatic, sometimes burning sensation in the mouth. The gram stain tells us the fungal hyphae, and the treatment is by topical application of nystatin or clotrimazole and 1% gentian violet, and if it is not regressing, systemic antifungals like fluconazole, ketoconazole, itraconazole, or the amphotericin B. Now, in these conditions, chronic hypertrophic candidiasis are also sometimes pre-malignant. The high incidence of malignancy is seen in these cases. So, it is persisting for a long time with surgery by excision and biopsy is the treatment of choice. Then, we come to another condition which is called herpes simplex and orolabial herpes. The human herpes simplexus virus is the one which is which causes this, and this is found in mucocutaneous junctions, spreads by contact and saliva, and it's quite a common condition where you have fever, malaise, headache, and sore throat and lymphadenopathy. These vesicles are formed, and they are the ones which produce pain. And so the treatment is viral isolation and culture, cytological analysis of the vesicles, serum antibody titers, which make the diagnosis, topical anesthetic mouthwash, vitamins. You should avoid definitely the steroids because they aggravate the situation. Now, the secondary infection of herpes simplex occurs in adults, wherein there is a reactivation of virus lying dormant in the trigeminal ganglion due to the factors are emotional stress, fatigue, fever, pregnancy, immunodeficiency, and trauma. The sites usually are the vermilion border of herpes. They have the lips. It's called herpes labialis. And recurrent intraoral herpes, the hard palate, and the gingiva. So they also appear as vesicles to start with and occur in erythematous and edematous mucosa, which rupture and the crusting forms. They heal without a scar formation. Treatment is the antiviral treatment and no steroids. Apart from the herpes simplex virus, you have aphthous ulcers, which are quite commonly encountered or seen by the clinician, wherein there is a superficial ulcer which is painful. Ulcers are superficial and very painful, and they are present mostly in the oral cavity, the vestibule, on the gingiva, and the cheeks. And locally, the etiological factors are the trauma and psychological effects, stress, the food and allergy, nuts, spices, tomatoes, chocolates. These are the ones which irritate locally and produce these ulcers. And sometimes the vitamin deficiencies, the hormonal, endocrine, and the viral, of course, the habitual constipation. Now, the recurrent, often multiple painful superficial ulcers in the oral cavity, they keep on recurring now and then, painful, and there is no systemic there are no systemic symptoms like fever or malaise. And these are usually divided into minor and major. Major part, and the minor ulcers are the ones which are very common. The major ones are a little less. Treatment is by avoiding spicy food, vitamin supplements, and topical lignocaine applications, and cauterization of the base with silver nitrate. And there is another condition which is called the tongue tie, and if the tongue tie is the one which restricts the movement of the tongue, and so you cannot project. So their treatment is very simple with this. It's only the mucosal band. You just make a cut into the mucosal band if it is a little thick. It is cut and parallelly and horizontally, and cut, slit and sutured vertically, so that mobility of the tongue is perceived. Then carcinoma, the oral cavity, there are various other benign malignant conditions. We'll deal with them later, and that is how. So to summarize, the oral cavity consists of the roof, floor, anterior, posterior, and lateral limits. How are these limits we have seen? How the mucous membrane lining is the squamous epithelium. How the floor is formed by the muscles and the tongue. The hard palate forms the roof, and then you have the oral cavity is divided into the vestibule and the oral cavity proper. The oral cavity proper, and we have studied the various muscles with which the tongue is attached to the extensor muscles attached to the mandible and the hyoid bone, and the intrinsic muscles, how they shape the muscles, they shape the tongue, and we have seen the functions of these the functions of the first digestive function. It is involved in the initial processing of the food, which is aided by secretions from the salivary glands. It manipulates the sounds that are produced, and by the movement of the tongue, the oral cavity is changed in its in the vibratory air column, and so produce various kinds of sounds, and which is called the speech. The basic mechanism of speech is studied. We'll study that later. So this is in brief the various conditions which affect the oral cavity: the submucous fibrosis, the various bacterial viral infections, the tongue tie, and the malignant tumors. Thank you.
నీళ్ళు తీసుకోపోవా? ఎవరు వస్తారా?
వస్తారా సార్? నేను చెప్తాను.
ఇది తీసేయాలా లేకుంటే
తీసేసారు.
తీసేసిందా?
అదే నా తీసారు.
ఇది ఎక్కడ పెట్టాలండి? ఇదేనా?
అదే అదే పెండ్రైవ్.
ఇంకే విషయాలు నన్ను తీసుకుని పావు పిల్లలతో వెయిట్ చేస్తా ఉన్నాను డిపార్ట్మెంట్లో నెక్స్ట్ క్లాస్ కోసం.
రోజు క్లాస్
ఎవరు తీసుకోకుంటే నేను వస్తాను. ఎవరు తీసుకుంటే బస్ టైం పాస్ కావాలి మనకు కూడా.
ఇదేంటి షుగర్ ఎక్కువ?
అది తెలంగాణ ఎండలలోనే ఇది ఫంగస్ ఇన్ఫెక్షన్ వస్తుంది బాస్. షుగర్ ఉందా?
ఏమో చేయించుకోలేదు.
అదే కంటిన్యూ టేక్ ఫ్లూకోనజోల్, స్టార్ట్ టేకింగ్ ఫ్లూకోనజోల్ వన్స్ ఇన్ ఎ వీక్ till it completely disappears. 150. Yes. చేయించుకోవాలా తగ్గేదాకా till it disappears. ఇంకా టాపికల్ ఏమో లోసరిల్ అని దొరుకుతుంది. లోసరిల్ లోషన్ వన్స్ ఇన్ ఏ వీక్ ఇట్లా పెట్టాలి. పెట్టేదంతా ఉంటుంది దానికి కాడి ఇట్లా. సో వన్స్ ఇన్ ఏ వీక్ పెడతా ఉంటాం. తీసుకోండి సార్. స్టార్ట్. Good morning everybody. So in continuation of my last topic, I decided to talk on lab diagnosis of HIV. So diagnosis of the HIV infection by lab is essential to confirm the disease and to monitor the progress of the infection. So what are the tests that are available? There are so many slides are there. This is PG slides. I will limit myself to only few slides which are essential for you to understand the HIV and how to diagnose. Practical points I am going to tell. So if you remember, the first infection was diagnosed and confirmed that is due to HIV virus in 1983. But the first test to diagnose the infection was identified in 1985. That is ELISA test. So afterwards this ELISA test persisted in our science for longer periods of time till we developed better test. Better means if you go to the history, there is one entity called window period. So if window period, if you use the older methods of diagnostic methods, the window period is more. So the average window period those days to diagnose HIV infection was 3 months minimum to 6 months. Now the window period has come down to the level of 3 weeks to 6 weeks. So most of our patients, they come under positive bracket of this infection after doing the 4th generation test. So we have got 4 generations of tests. I will tell in the subsequent slides. So this CDC has recommended for HIV screening depending upon antigen and antibody. Both types of tests we have. And lastly, viral culture, which is not feasible because it's expensive, time consuming, and chances of infection to the lab persons are very high. So what are practical? That is ultimately identifying antibodies and detection of antigens. The first test to become positive is viral RNA. So it will be seen within a week after the entry of the organism. So that is called viral RNA, RT-PCR. Now what we are doing for COVID, same thing. So RT, that is real-time polymerase chain reaction. So that is actually most important diagnostic test, accurate and as well as it gives early the reports. The next test that it becomes positive is P24. So if you remember, when we talk about the structure of the HIV virus, this is a group antigen. So from there, this 24 antigen is identified. That's otherwise called capsid antigen. So this is the antigen first it comes to actually into the blood circulation for identification and spread of the infection. So afterwards followed by GP41. So these are the two antigens, but we have tests only to detect P24 antigen. But the fallacy of this test is P24, it appears early and disappears early. Because why it disappears? Because this antigen will be neutralized by the IgG antibodies that are produced subsequently. So whenever you are sure of the diagnosis of HIV infection, but the P24 antigen shows it's a negative, so we'll have to try to dissociate the complex antigen-antibody complex by acid dissociation test. So where the P24 is separated from the antibodies, then we do the subsequent routine tests. Then that will give a correct, accurate positive reaction. So that's about P24. Then lastly, we have antibodies, which appear as late as minimum 3 weeks. So these antibodies are IgG dependent antibodies. So unfortunately, we don't have any test to detect IgM antibodies. So the IgM antibodies, it makes entry first into the blood. But they are large in size, molecular weight, more than 500 molecular weight. So that is the reason this will not enter into all the body compartments. Example, from mother to child transmission. So you will not see the IgM antibodies in the child because it doesn't cross through the placental barrier. So what you look for is IgG antibodies. So these will be captured easily by ELISA test, and we got various methods of tests now. Rapid tests, ELISA tests, and rapid ELISA. Various types of tests are there. We try to time permits. I will tell other methods of tests. And we have 2 more tests that is actually written in the above lines, that is to determine the stage of infection as well as the response to your treatment. So stage of the infection, whether the patient is rapid progressor or typical progressor or long-term non-progressors. So these things can be known by these tests. That is CD4 count we do for immunological test, CD8 enumeration, then viral markers, that is viral load we do, RNA virus load. That's again real-time PCR, we multiply that, we have probes are there, PCR probes. So particular area of that chain will be focused, then that will be counted, matched with the data which is actually collected from various sources. So that's how we read, and counter will be there. It's usually counted by the laser counter. So whether CD4 count, they will be counted by laser light. So So in the molecular level it will be counting everything automatic. Then after these tests, introduction to these tests. Now look at this slide. Where exactly the whatever all I told, this is actually summary of this. In x-axis it is mentioned time zone, time in days, and in y-axis it is mentioned virus and antibodies. So the first thing that makes entry into the blood is PCR, RT-PCR. That's represented with the blue line. So it is a day 1, it is present in the blood. Then afterwards P24. That red line is RT-PCR, and the blue line little below. The blue line is little below than the red line. So this is P24 antigen. And now with this, after 2 weeks, the infection is well established. There is rapid surge in the level of the virus, and at the same time P24 antigen. And this will continue till the appearance of antibodies. That is after 3 weeks. Here it is wrongly shown. It's a 21 days. 21 days is IgG antibodies, not IgM. IgM antibodies, they appear in 7 days of the infection only, but that we cannot capture. So far we could not identify a test that can identify IgM. In fact, most of the tests what we are, except herpes viruses, most of the tests what we are doing is actually detects only IgG antibodies. So this reaches the maximum in a 6 weeks time. So then it sustains throughout the life. These antibodies can be detected at any time, unlike P24 antigen. So P24 antigen is coming down. The blue line you are again seeing at the level of 65, 70. So it continues to maintain that line, lower line, because the antibodies are neutralizing these antigens. So other antibodies can be produced apart from the P24 and GP41, that's the envelope antibody. So some other antibodies will be actually manufactured like Ig antibodies, like IgM antibodies, but they are of no value in diagnosis except neonates. But in neonates also we don't have so far a test to diagnose. So what is the purpose of test? This why we should test? That means to diagnose the case as early as possible and do proper counseling. That means what exactly you are supposed to tell. If it is negative, now you escape the infection, but it's not always so. Tomorrow again you may get the infection if you indulge in the same modes of sex which enhances the transmission of the infection from the partner to you. So behavioral change, counseling should be given, and lot of time should be spent, because after all it's a very human being. It's very difficult to change their mindset. And if it is a positive, then you should give a counseling, separate counseling for positive reaction, where you tell them that you got infection. Now is a time that you should not marry. If you are already married, then don't have indulgent sexual activity with your partner or extra marital partners. At least do this favor to the society by not indulging in extra sexual activities. If the sex is inevitable with a spouse or under the influence of alcohol or drugs, if it is inevitable, we discourage. But when it is inevitable, they should use always condom. And not only that, condom, they should start ART as early as possible so that the viral load will come down, CD4 will go up, and so that the infection is not transmitted to the other partners. So educate the patient regarding all these risk behavior and how various modes of transmission, and start ART. So these are the mandatory tests like antibody identification, that is screening test, not only for the case to identify the case, but also in the blood banks. So we have got various methods of testing. I will tell in subsequent slides. So in the blood banks where they are supposed to donate the blood to the recipient. So we are supposed to screen their blood for evidence of any infection. That's most important. And another sector of our patients are those who are going to donate organs, not only blood, tissue, sperms, and organ donations. So there also we are supposed to screen mandately. And another sector of people, that high risk people. Now this definition of high risk is going away because we don't know who has got previously we were used to all this sector of patients, that is truck drivers, sex workers, homosexuals. So this is not so now today because of the changing scenario and different modes of practices and change of the mindset of the patients in the society. So anybody can prone for this infection, even a doctor or anybody, a nurse, student, a businessman, a politician. We have seen all types of clients in our practice in the last 40 years. So we see that 40 years of epidemic. There's 4 decades of epidemic. So we have seen all types of clients, and they should come forward voluntarily for testing. So they should opt for testing so that we can help them actually in combating the stress of identification. So there are the various methods of the tests, and they are all used in WHO testing strategy. So same thing adapted by NACO, National AIDS Control Society, and in turn the State AIDS Control Society, the SACs. We got AP SACs. So far Telangana SACs are not formed because it's been almost doldrum. There is no supplies, proper supplies of the medicines or kits, testing kits, or a safe blood bank. So it's not working like in the beginning, that is for 30 years back. So the SACs, State AIDS Control Societies, AP SACs still existing in the Sultan Bazar, that's Koti area. So they work independently after taking guidelines from the NACO. NACO in turn takes guidelines from the WHO. And here we got 4 types of testing strategies. The number 1 testing strategy is used in the blood bank, where the only one test kit is used. If the patient is labeled as positive, we discard the blood and we refer the patient for further testing and counseling to the ICTC center, Integrated Counseling and Testing Center. If that is negative, then we send him for the further preparation for blood transfusions or blood products or tissues or organ transplantation. So this is how we use this testing strategy number 1. Instead, testing strategy number 2, we use 2 test kits, because here we are used it as a screening test. So screening test most of the time in our country is done in the antenatal women. So the antenatal women are provided with the free testing in all antenatal OPs. So they utilize, because they don't want to take any risk. So they take 2 tests. One, if it is positive, If it is positive, they retest for second kit. If it is negative, no. So negative test result has got more positive predictive value than a positive test. So as a positive test can be a false positive, but never a negative test. Similarly, if the second test shows it's a positive, we label as a positive case. If it is negative, we label it as a indeterminate. So here the positive test is made to wait for few more months for retesting, third test maybe. So that time if it is negative, we label it as completely negative. That means pregnancy is prone to develop incomplete antibodies in the blood. So false positive reaction is very common in pregnancy, apart from autoimmune disorders or any chronic infections. So that is the reason we do only 2 tests in antenatal OPs. And in testing strategy 3 means to high risk people like STD OPs, where the patients already present with the history of exposure or history of any STD like genital ulcer disease or a growth or a discharge per urethra. So all such cases should be provided 3 test kits. Same thing, 1 test negative, although there are positive symptoms are there, results are there, we still label it as a negative case. And again, we don't leave such patients because the high risk patient, we ask them to come back after 3 months for retesting. Similarly, so the first test is positive, we submit it for second test. If both are positive, we label them as a positive. If again second is negative, we submit it for third test. So like that we proceed with the testing. But nowadays, that is also changing slowly. Now, example, in my practice, let me share that we do only 1 test. That is the latest 4th generation test has got accuracy to the tune of 99.99, both specificity as well as the sensitivity. So this is what famously called a tri-dot test. The beauty of this test is not only identifies HIV-1 infection, it can also will tell whether it's a dual infection, we are dealing with 2 infections, or isolated HIV-2 infection. So that's called tri-dot test, what we are using. So previously we used to get it confirmed by the Western blot, that is supplemental test. So now this is not seen nowadays. Nobody goes for the confirmatory test for Western blot. Still some people who are half knowledgeable persons, they send for now you do Western blot. Because that's costly, expensive, 1500 rupees, it takes time consuming, sometimes that also may give false negative reports. So in spite of selling for Western blot, I do only 1 ELISA test, rapid ELISA, what we say, rapid ELISA. If it is positive, we label it as positive. And if you associate symptoms, that means HIV related or AIDS related symptoms, definitely we start ART without any hesitation. But when there is a risky behavior or patient denies, then we can send for so-called Western blot or other types of tests. But till today, in NACO guidelines are, they always confirm with another ELISA test, rapid card test. So 2 tests are positive, they will label as a positive. If 1 is negative, they don't accept. Negative report is even more important than positive test. So this is all what I repeating, very high sensitivity, 99%. So enzyme linked test. The old enzyme linked tests, they were taking a lot of time. So it takes more number of samples at a time to start the test. Say 99 tests are required to start the test and 1 is controlled. So total 100 wells will be there in the ELISA test. Time consuming, of course a little cheaper, but time consuming and requires optical densitometer to read it, and not only that, we require a specialist technician to run the test, because a lot of mixing will be there, washing, mixing, and those ELISA wells will be there. They are coated with the antigen, then sometimes they are coated with antibodies. So vice versa, we put that reactant, then we put substrate, then enzyme, which gives color change, and this color change is read under optical densitometer in some other room with a specific so depending upon the color change, we label as a positive or negative. Suppose it's a pink color actually, that is positivity, but if somebody has got a color blindness also, sometimes they label it negative. So these are the design. I told that I will talk about this what are the first generation test. So these are the first generations were giving lot of false positive reactions, because the antigens are prepared from the viral lysates, because the virus is subjected to lysis by adding detergents. So these viral particles, after breaking down with the detergent, they are actually utilized for doing the test. That's called first generation ELISA. So associated with lot of false negative or false positive reactions. So now nobody does that. It's a very insensitive test and less specific. So we went for the second generation ELISAs. So they were actually recombinant antigens. They are expressed from the bacteria and fungi. So here we are not taking the antigen cell, but recombinant antigens we are taking. Recombinant means they are manufactured, that are artificially prepared antigens which are expressed from both fungi and bacterial, and these are used as a lysis, viral lysis. But that also associates a lot of contamination. So they are also, because it contains yeast cell. Yeast cell, they are associated again false positive or false negative reactions. So that also we are not using. Now the third generation of what we are using is the synthetic oligopolypeptides of the virus. They are used, which contain about 15 to 40 amino acids. They are called synthetic peptides. So that means they mimic just like HIV virus, but they are synthetic peptides. So it will reduce that incubation period from say 6 months, 3 months to 6 months to 3 to 4 weeks. So that is the sensitivity of this test, 3 to 4 weeks, third generation. Then we got the latest is fourth generation ELISAs. For the last 5 years we are doing this. So what is the beauty of this test is it will identify both the antigens as well as the antibodies. And this actually detects B24 antigen and simultaneously antibodies also, because the wells are coated with antigen as well as antibody. So in both ways, the infection finding cannot be escaped. So there are all the first generation, second generation in schematic representation, and that various methods of this antibody detection, that is indirect detection, then competitive detection, and sandwich type of detection. That is between two antigens, the antibody is sandwiched. So these are the various methods of detection, antigen-antibody reaction. This is indirect ELISA, wells, and this is sandwich ELISA, competitive ELISA. So the various reasons are there for false positive reaction. The one I told is pregnancy and autoimmune disorders, multiple blood transfusions, and some viral infections, and technical error. These are all the reasons. For some any chronic infection like chronic malaria, leprosy, so they all produce false positive reaction. Then few causes for false negative reaction. So technical fault, or when the patient is in a window period, that means he int start producing antibodies. So this also. Then late stage, when actually there is a immune collapse. What we say the late stage, there is no immune system that is remaining which will elicit antibody response. So antibodies completely fail to product because all the lymph nodes are actually destroyed, atrophied, and nothing is there to react and produce antibodies. Then rapid test. What all told, we will be completing this antibody test within 30 minutes. So this discriminates both HIV1 and 2. So this part test. So they are very easily available and easy to do, even at the point of care also. Suppose in camps, you can do immediately results, you can show camps or blood banks or even STD clinics, even antenatal OPs also. So they are very easy to perform and duration is just within 20 minutes. Results are ready and cost effective. Though it is a little expensive than ELISA, but it is very sensitive, very specific. So we are again how they do ELISA, particle agglutination, comb test. That's where this, we do rapid test. Rapid test we do by 3 methods. One is particle agglutination and comb test. It appears like comb. Then microparticle technologies and particle agglutination. And lastly, the supplementary test. Already I told about little interaction to Western blot. Western blot, we are going to detect if the patient has got all the antibodies, so it can detect all the antibodies. So here the viral lysates are subjected to diffusion, electrodiffusion on the nitrocellulose paper. So depending upon the molecular weight of the individual proteins, if you remember in my structure of the HIV virus, I told there are about 3 structural proteins, 3 accessory proteins, and 3 regulatory proteins. So the total 9 proteins will be actually they are adherent to this nitrocellulose membrane, and when you put blood drop containing antibodies, so the corresponding antigens will be show a color change or a shadow. So band will be visible. These bands are actually measured and labeled as which antigens are positive. So at least 2 antigens should be positive to tell the patient is positive, mainly the GP41, P24. But when other antigens are present, other than the 2 antigens, we label it as a indeterminate test, again subject to the second test after some time. That's our Western blot. Same thing we told. Yeah, this is Western blot cut into many pieces, but you should not cut very narrow, otherwise the sensitivity of the test will be decreased. You should, this right side, they are all cut into very narrow strips. They are not at all useful for the test. And in a lab, some people, private people, they cut into multiple pieces and do the test. So what is the sensitivity of such type of test? So it should produce sufficient amount of band, color change. Then only you can appreciate the band formation. If the bands are properly not developed, again we subject the patient for second test after some time. That test report will be indeterminate. So 3 types of test reports we give: positive test, negative test, and in between indeterminate test. So this is modification, mainly to differentiate between HIV 1 and 2, because previously we were having only HIV 2 test for Western blot. So now we are actually started impregnating that nitrocellular membrane with all the both antigens from HIV 1 virus and HIV 2 virus like P24, P26, GP41, GP36 and VPU, VPX. Like that we identified these individual proteins, then started doing to identify 1 or 2. So this again one more immunoblot to identify between HIV 1 and 2. This is also recombinant synthetic HIV protein. This is antibody test, rapid HIV test. So this rapid HIV test you can use various media like including any body fluid that contains blood or blood products that you can actually test it. Example, this Oraquick. Oraquick is a saliva test. Though the virus is little inactivated with the help of salivary enzymes, but still Oraquick is a very sensitive test, it can detect. The advantage of this Oraquick test is it's not invasive, so you can do tests easily. This is the Oraquick. And we have got confirmatory test apart from Western blot. Viral isolation is P24 or culture sensitivity is also 100% specific and sensitive. P24 antigen we talked enough on that P24 antigen, and PCR we talked enough. The various methods are there. There's branched DNA and RT-PCR, real-time PCR, then transcription mediated amplification, then we've got nucleic acid sequence estimation in special body fluids like genital compartments. You want to see the amount of virus in the semen or vaginal fluid, so this NASBA is used. Similarly for branched DNA for research purposes. So what we are detecting, viral load, that means RNA and number of copies per ml of the blood we are detecting, and the sensitivity of these tests is to the tune of 50 copies it will detect. If the viral load is less than 50 copies in the blood, it shows as a negative test. That doesn't mean that he is not having any virus in the body. If the patient is on highly active antiretroviral therapy, the viruses will be reduced in the body to the tune of undetection. So that is the reason not used for diagnostic tests. These tests are very useful to monitor the treatment, response to the treatment, or to identify the sensitivity. So there are the various methods what I already told. Strategies already finished. So what are the tests, whether we have any tests in the window period, that I already told, RNA PCR and P24. Again repetition whatever I speak on this topic. So this is in summary again, what are all we do. In the neonate also, that's what I told, IgG antibodies or DNA PCR. So DNA PCR is better than the RNA PCR, because you are going to detect after the entry of this RNA PCR into the nucleus of the host cell. So they better maintain in that area as a latent infection. So even the peripheral blood mononuclear cells also, since they are archived in those cells, so they can be identified from there also. DNA PCR is better test than RNA PCR in the newborns. So if you know this CD4 count or viral load, you will know nearly what is the status of the patient, immunological status, virological status, or whether he is going to clinical failure. So first thing that appears is the virological failure. When the virus starts multiplying unabated because there is no drug to act, so it multiplies, produces viremia to the extent of more than 55,000. So that's the time we start decreasing CD4 cells. Once CD4 cell starts decreasing, we go into the immunological failure. So we combine the virological immunological failure, ultimately end up in the clinical failure. So this clinical failure means we start producing all the apoptotic infections. So depending upon the CD4 count, you say start to the beginning, when the CD4 count falls below 500, you just superficial fungal infections or some common viral infections like herpes zoster. But when this further falls below, it can produce deep fungal infections or a PCP pneumonia when it falls. We got specific infections which may appear at specific time. So this well shows this, well depicts this slide. So first thing that when is little fall in the CD4 count, herpes zoster virus appears, herpes simplex virus, then superficial fungal infections, when it falls at 200. So PCP will appear, then when it falls below 100, cryptococcosis, then it further falls below 50, you can get cytomegalovirus or retinitis due to CMV retinitis. So, or MAC infections. MAC infections are what? Atypical microbial infections. Mycobacterium avium complex. So this is the viral load determinations. And lastly, this is the only test that is actually remaining in today's class, that is HIV viral resistance testing. So we got two types of testing, phenotypic testing, genotypic testing. So what we are trying to know is genotypic testing. Phenotypic test is just like antibacterial resistance test which we do in our lab, that is giving some high concentration of the drug, antiviral drug, then allowing it to grow. So just like antibiomo where the bacteria doesn't grow, all around that antibacterial powder. So same thing here also. So these are not accurate and very difficult to conduct this phenotypic resistance. So that is the reason we go for genotypic resistance. That means study of the genes actually, genetic makeup of the individual, where exactly they are acting or not acting. And lastly we got one more diagnostic method is called, that is co-receptor study. Because certain viruses we got tropism, for CCR5, CXCR4 tropism viruses are there, and we got now drugs like Miravirac which actually anti-adherent to the CCR5 receptors. So it prevents attachment of the virus to the CCR5 receptors. So thereby it prevents the entry of the RNA. So it's the first level only. So Miravirac can act. I think this ends my talk on lab diagnosis. Thank you.